Hi everyone, welcome to our webinar tonight. We're not going to be talking about genetics and family planning tonight. So as many of you know, the Immunodeficiency Foundation assists people with immune deficiencies. We work in areas around education, awareness and advocacy. And tonight we've got Rebecca McIntosh, who's a genetic counsellor, talking to us about family planning, genetics and immune deficiency. So this is our last formal webinar for 2021. The year's very quickly coming to an end. So the format of tonight will be a little bit different. Rebecca's going to talk and then she will pick up any questions that you have and answer those questions. So please pop your questions in the Q&A so Rebecca can see those. At the end of the webinar, if you would also like to just complete the polling questions, which I've already launched, that would assist us in our planning for 2022. So I'd like to wish everyone all the best for Christmas and the new year, and we'll certainly be back in 2022 with another series of webinars. But without any further ado, I'll hand over to Rebecca to chat to us tonight. Thank you.
Thank you very much for having me on today. So my name is Rebecca McIntosh, and I'm just going to start my presentation. So I'm a genetic counsellor at Sydney Children's Hospital, and I'm going to be chatting to you a little bit about family planning. And I guess this is, I want to preface the conversation today by saying that this is a bit of a challenging topic for lots of people. And so I'm going to, I guess, stop and pause at several places along the path, because this whole session is recorded, and so if there's anything that raises any issues with you, I think my contact details will be available at some point, and I'll put them in the chat as well. So if you want to have a kind of like one-on-one conversation, that's fine, we can do that, but also you may want to just come back and revisit this in your own personal time. So the goal of today is to kind of have a bit of a chat. I don't know if you dialed into my talk last week, just a little bit about the genetics of immunodeficiencies, but we're going to do a very quick revision of genetics and how your condition may or may not be diagnosed from a genetic point of view. You may have a clinical diagnosis. And then I'm going to give you some information, and the goal is to educate you about and provide you with information about your family planning options in terms of your immunodeficiency. And then as a kind of separate aside issue, talk about reproductive carrier testing, which is an option available to anyone having a baby. So that's the kind of goal of the talk. Okay, so I guess I will preface this by saying I don't know who's on the line and I don't know your backstory, but there are lots of different ways that people can come and see somebody like me, or maybe people have turned up today to kind of find out this information, and there's no right or wrong path or the correct way to come to here. So the process to get either a diagnosis about an immunodeficiency or even a genetic diagnosis will be slightly different for everybody. And here's a couple of scenarios, but this is not by all means the exhaustive list. So maybe you saw your immunologist and you were given your immunodeficiency clinical diagnosis first, and then they did a genetic test on you and it was confirmed as to which specific gene it was with a genetic test. Alternatively, perhaps they said, well, you definitely have an immunodeficiency, but we're not sure which one. And then they came in and they did broad genetic testing. They did lots of different genes all in one go. And then they confirmed which one on the genetic test. Or alternatively, they said you've got an immunodeficiency and we did genetic testing on you and we didn't find an answer, but you still have an immunodeficiency. That genetic test never changes that clinical diagnosis, or some other combination of the things I haven't said yet. So that all of those are all valid. But I guess we will talk a little bit more about which options we can offer you prenatal testing in. So if you have a confirmed underlying genetic cause, i.e. we've found the actual DNA change or combination of DNA changes in you, then that helps us talk about how the condition was inherited, or if it's a new change in you, that helps us talk about other implications for other family members, and we can talk about family planning, which is why we're here today. If though we haven't found a genetic cause or you've never had a genetic test, then either we have to wait for more testing to be available, or you need a genetic test, because we need that genetic test answer in order to be able to provide you with options for future family planning. So without that, we cannot provide testing in a future pregnancy, because we can't provide you with the information about family planning, but with that, in terms of your inheritance pattern. We can provide you with some general guidance, but we need the information about the person who's got the condition in the family. We need their genetic result before we can test in a future pregnancy. So hopefully that's clear so far, that we really need the result in the person who's got the condition in the family, either yourself as the affected person, your partner, or your child, or your parent, or whoever, before we can do any testing on a pregnancy.
I have keys, you can ask.
Okay, someone's got their microphone on, just letting you know. Okay, perhaps you had your diagnostic test done via just one single gene. You know, we've made up of billions and billions of cells, and inside our cells is our instruction manual, and we've got 20,000 genes inside every single cell. Maybe we just did one gene at a time, and maybe they found the answer just on one single gene. Maybe we tested a whole bunch of genes in one go, so maybe a couple, like maybe 10 genes, maybe a couple of hundred. That's called a panel. That's probably pretty standard these days if you've had testing in the last couple of years. Maybe we looked at all of your genetic material. It's not quite all of your genetic material if you came to my talk last week, but I guess it's kind of a useful euphemism, it's called an exome. Most people these days, if they've got just an immunodeficiency, they probably had a panel or a single gene test. It doesn't matter so much if you don't know what kind of test you had, as long as you know what the answer is in yourself. And I guess you may or may not know the pattern of inheritance, but your immunologist or your genetic counselor can tell you what the pattern of inheritance is. And I'm going to go through the types of patterns of inheritance now. So there are three main patterns of inheritance in single gene causes for immunodeficiencies. They're called autosomal dominant, autosomal recessive, and X-linked recessive. So autosomes are the genes that are the same between boys and girls. And so they are the ones that don't matter whether you're a boy or a girl, and X-linked are the ones, the genes on the X chromosome. You might remember from high school biology, girls have 2 X's and boys have an X and a Y. So the genes that are on the X chromosome are important in terms of whether they may be inherited from a boy or a girl. Okay, so for autosomal dominant inheritance, you may remember if you came to my talk last week that it's not gender specific. So in this example, on this image, it's inherited from a man, but actually it could also be equally inherited from a woman. And every time we make a baby, you will pass on either one of your genetic copies of your gene or the other in your sperm or your egg. So all of our genes come in pairs. We get one of our copies from mom and one of our copies from dad. And all of our cells have two copies of every pair, except for the sperm and the egg. The sperm has, and we pass on one or the other. So every time we make a baby, there are always 4 combinations, because it's a combination of one from mom and one from dad. So in this example, in autosomal dominant inheritance, if an individual is affected with the condition, you can see this is the capital D. This is the copy of the gene that is affected. So there are some genes it's really, really important to have 2 functioning copies of the gene. And if you've got one that's got a change in it, then that will be enough to cause the condition in yourself or your child or your family member. If you as the individual has the condition that's inherited in a dominant fashion, then you will have a 50% chance of passing the condition on to your children, because you've got one with a change, one that's normal. You will either pass on the one with the change or the one without. So you can see here, this one in the black is the one with the change, and 50% of his children, either boys or girls, will inherit the change. That's autosomal dominant inheritance. One example of that in PID is STAT1 deficiency. Differently to that is autosomal recessive. So again, these autosomal dominant and autosomal recessive affect both boys and girls. And so unlike in autosomal dominant, there are some genes where it's totally fine to have a change in one, but you got a backup copy, you can totally carry around the change and you're totally fine. So if you've got the functioning copy, that capital R, but you've got one with a mistake, as long as you've got that capital R, you're totally fine. But if both parents happen to carry the change, then they can pass on that combination of the two changes, and that baby will be affected. So if you are a person who has no functioning copy of the condition, you will express that condition because you don't have any backup copies. If you are the person who has the condition, you have no functioning copy of the gene, the likelihood of you having a baby with the same condition in an autosomal recessive fashion is very likely to be low. The only way that you can pass the condition on is if your partner is also a carrier. And these conditions are usually rare in immunodeficiencies. So it's most likely that your future partner or your current partner is actually a person who is not a carrier. But if you are an individual who has a recessive condition, we should screen your partner doing genetic testing to see if they are also a carrier of the same condition. If they are, then it would be a 50% chance that your children are affected, because if you are a carrier, all of your children will be carriers. If you are affected, all of your children will be carriers because you can only pass on the change. But if your partner is not affected, your children will only be carriers. It is not an issue for your future children. So hopefully that's clear. But if you are both if you are a parent of a person who has the condition, so it's this scenario, then we know it's a 1 in 4 risk. X-linked recessive inheritance, so also recessive, but this is a sex-specific condition. So this is a condition that usually only affects boys. It's inherited on the X chromosome. Boys have an X and a Y, so they don't have a backup copy of the gene, and so they will express the condition because they only have their one X. So as soon as you have a change on the X, you don't have the backup copy and you'll express the condition. So females who carry conditions on the X chromosome are at risk of a 1 in 4 risk of having a baby with the condition, a boy. Men who have X-linked recessive conditions do not have a chance of having an affected children, but all their daughters will be carriers. Their boys are unaffected because they inherit their Y chromosome from their fathers. Hopefully that's clear so far. So that's kind of a recap from last week. So really, I guess the reason that you're actually here is to talk about, well, now if we know why we did the test and we know why, how it's inherited, what about the actual family planning? What are my options? So I guess some generic kind of general advice about having a baby. So I would encourage anyone who has a genetic condition who's being treated, particularly the women who have a genetic condition and thinking about family planning, to consult with their treating doctor. So if you have a PID, you should see your immunologist before you get pregnant. And ideally, I mean, if it's an accidental pregnancy, there's not much you can do, but ideally before you get pregnant, because there may be an alteration to your current treatment plan in terms of pregnancy. My understanding is that IVIG is very safe to use during pregnancy. They don't need to take you off it, but there may be other medications that you are currently taking that you may need to modify in terms of managing a current pregnancy. So I would encourage you to have that conversation with your immunologist early. I'm hoping that they would already be having that conversation with you. There's some other general health advice for any couple having a pregnancy, and that includes taking high-dose folate. unless it's for some reason contraindicated by your healthcare provider, but please have that conversation. High dose folate is proven to reduce your risk of having a baby with a neural tube defect like spina bifida, and it can be found in over-the-counter pregnancy vitamins. We usually suggest you start taking it 3 months before you start trying for a pregnancy. Again, if you are unexpectedly pregnant for some reason, you should be taking it as soon as you know you're pregnant through the first trimester. And you can just take folate if you don't want to take the rest of the multivitamins, but high dose folate. Okay, so I'm going to now talk about, so in terms of family planning, like I said earlier, we can provide you with advice about future risks and options for family planning if we know the underlying DNA cause in the affected person, and that would help, that might have come on a genetic test, and that will help us interpret the inheritance pattern. And I'm now going to talk about what your options are, some of which may be confronting information. Please be aware there is no right or wrong option. The goal of the rest of this talk is to provide you with information. So if you feel that this is too confronting information, this is recorded, you can come back and watch it later. So, like I said, we may be discussing some challenging content. Feel free to leave if you feel you need. So, there's no right or wrong option. This is a personal choice. Some people, in fact many, often have a preconceived notion about what options they want prior to pregnancy. So I have many families who come in and say, well, I definitely will want a particular test, and then they get pregnant and they say, well, now I don't know what I want. Or they say, well, I will definitely do XYZ, and I'll definitely want ABC test, and then they get pregnant and then they change their mind, and that's fine. We're never going to hold you to whatever you said, 6 months before you got pregnant. The goal of, if you see a genetic counselor, if you see somebody like me, our goal is to provide you with the information, but also to have a conversation with you to explore how you're feeling and help you make the right decision for you and your family. And it might not be the same decision every pregnancy. So sometimes the first pregnancy you might feel one way, and then you've gone through that experience and you change your mind the second time around. That is also fine. So it's an evolving conversation. Okay, so I think some questions to think about in the back of your mind as we go through the next couple of slides, because I think there are sometimes before you've ever thought about this before, and before you've ever been given this information, you've never really had to think about these. So some questions for you to think about with you and your partner. So is this condition inherited? Are you at risk? And would you consider testing in a pregnancy? And I'm going to talk you through the testing options. What would you do with the information if you got it? So would you consider stopping a pregnancy? Do you just want to know so you can plan when the baby's born? Are you willing to put a pregnancy at risk? Some of the tests have risks of miscarriage. Would you prefer IVF? Would you consider testing just the baby at birth to make a plan for vaccines if some of them vaccines are contraindicated, or just screening the baby to see if it's a risk over time? So I have those in the back of your mind as we move forward. Again, no right or wrong option, and that those options may evolve over time. So I like to think of your options, and this is for you to have a biological baby of your own. I'm not going to talk about surrogacy is an option, but I'm not going to talk about adoption. I'm not going to talk about fostering. But this is for you to have your own biological baby. So there are kind of 5 main options. Once we know what the molecular cause, the DNA cause, is in the family. So option 1. I always put this as the first option, although usually by the time you get to somebody like me, this is not a valid option anymore. You want to do something, but option 1 is to do nothing. You don't have to do any testing in a pregnancy. You are not obligated to do anything. You can get pregnant and have your normal screening in a pregnancy and just proceed and have the baby. Completely valid option. Because there's not much else to say about that, I'm not going to talk any more about that, but I want you to know that that is on the table. Option 2 is a naturally conceived pregnancy and a test called a CVS. I'm going to talk about that next. Option 3 is a naturally conceived pregnancy and an amniocentesis. Option 4 is an IVF or in vitro fertilization and then pre-implantation genetic testing or PGT. And option 5 is gamete donation. So I'm going to talk about options 2, 3, 4, and 5. So what is a CVS? A CVS stands for a chorionic villus sample. So it's a test that's undertaken at about 12 to 13 weeks gestation. So you get pregnant naturally. We usually send you off for a dating scan at about 8 to 9 weeks. So what normally happens is you've already kind of known to some sort of service, and what happens in my service is you ring me at about 6-7 weeks. Hopefully you've told your partner first, don't tell me first, and then we send you off for a dating scan. And the dating scan is so we get your dates right, because we don't want to do the test too early, we don't want to do the test too late. So at about 12 to 13 weeks we do the CVS, and essentially what we're doing is we're taking a sample of the chorion. The chorion is the placenta, and it's under the guidance of, the test is done under the guidance of ultrasound. What happens is at conception, when the sperm hits the egg, the cells are copied and then they divide. And they keep copying and dividing. And a bunch of those cells, the same DNA and the same copy, go off and make the placenta, and a bunch of them go off and make the baby. So it's the same DNA in the placenta as in the baby. So we can biopsy the placenta and we can test that because it will essentially be the same as the baby. So under the guidance of ultrasound, we can take a sample of the chorion and we can determine if the baby has the same genetic condition as the affected person in the family, because we don't have to sample the baby. There is a small risk of miscarriage. The quoted figure is about 1 in 100. So if 100 women have a CVS, about 1% of them will have, about 1 will have a miscarriage. Part of that is that there is a background risk of people who will miscarry at about 12 weeks. It's still, unfortunately, relatively common to have a miscarriage at up to about 12 weeks. So the test itself is very safe. You will do it in a place that's relatively safe, but there is still a background risk of you having a miscarriage anyway. So it's not all to do with the procedure, but they will quote about 1%. This test is available at most large public hospitals and also in private locations. And so that what they will do, the result was available about 2 to 3 weeks. And what they will do is test both for the thing that's in the family, whatever genetic conditions in the family, and also for other common chromosomal problems. So all our genes are on structures called chromosomes. And so they will look for other common things, which is usually extra genetic material like trisomy 21, which is Down syndrome, or trisomy 13 or 18, and some other kind of small genetic problems, which are common for anyone who's having a baby. And that result will be usually available between 2 and 3 weeks. So at that point, you're usually about 14 weeks. If you're less than 14 weeks and the baby is affected with either some other genetic condition or the genetic condition that is in the family, and you would like to opt for a termination of pregnancy, that would be done by a surgical termination where they give you a general anesthetic and they take you into theatre, you wake up and the baby is gone. Okay, so that is a CVS. This is a picture of a CVS. It's either done transabdominally, so under the guidance of ultrasound, they take a sample through the abdomen, or depending on where the placenta is, it's done transvaginally. I don't have a picture of this here, but there is this booklet here, which I will put in the chat at the end, is a very excellent summary of all your different options. So it's the one booklet. I've just taken this one snapshot. So all the snapshots from the rest of the talk are from the one booklet. So they can sample the placenta. They don't go anywhere near the baby, which is why they do it under the guidance of ultrasound. They give you a local anesthetic, so nominally you don't feel anything. Okay, so option 3, so option 1, nothing, option 2, CVS, option 3, amniocentesis, is a very similar test to a CVS, except it's done a little bit later. The test is done from 15 to 19 weeks. And so again, under the guidance of ultrasound, we sample the amniotic fluid. Floating around in the amniotic fluid is cells from the baby's skin, and the baby's kidney because the baby is urinating into the amniotic fluid. And so there are kidney cells in there as well. So we can sample some of the baby cells that's floating around in the amniotic fluid. Just like the CVS, we can check for the same DNA changes in the affected individual, but this test is a little bit safer, partly because you're a little bit further along in the pregnancy. You are still putting a needle into the uterus, so you're tampering with the environment, but because you're a little bit further along, the background risk of miscarriage is lower. So the risk is 1 in 200 or 0.5%. So if 200 women have an amniocentesis, one of them will potentially have a miscarriage. Again, it's available at all large public hospitals and also in private clinics. Again, the results very similarly take usually about 2 to 3 weeks, and it will also test for the same common chromosomal issues that are tested on the CVS. Because you're later in pregnancy, over 14 weeks, usually from 15 weeks onwards, if you want to stop the pregnancy, then that would be done via induction of labor. So this is a picture of an amniocentesis. So under the guidance of ultrasound, they sample here and they take a sample of the amniotic fluid and they send that off and they can get the cells out of that amniotic fluid. Okay, option 4 is called pre-implantation genetic testing. It used to be pre-implantation genetic diagnosis, but it's just had a name change. So if you've ever heard of PGD, this is the same thing. So PGT is done via in vitro fertilization or IVF. So a lot of people like this as an option because there's no requirement for the consideration of termination of pregnancy, as they will only re-implant unaffected embryos. So you go through the IVF process, they make a baby in the petri dish, which I'll show you on the next slide, and they'll only re-implant unaffected embryos because they will test the embryos before re-implantation. Unfortunately, at the moment, it's only done at private IVF companies, and up until the beginning of November, there was an out-of-pocket cost of approximately $6,000 to $10,000. So the IVF component is covered by Medicare, but I have an update for you because when I originally wrote this talk a couple of weeks ago, there wasn't one, but there is new legislation recently announced as of the 1st of November, which means that some people may be eligible for a Medicare rebate on PGT. So some of the IVF component is already Medicare rebatable, I think for maybe 1 or 2 rounds, but then the PGT component was always out of pocket. So that was where the main money was came from, and I'll show you why on the next slide. So I don't have, because it's very, very new legislation, I can't guarantee that you would be eligible, but I want to talk you through what I think it's worth asking the question. So the eligibility for this rebate, they call it a rebate, but I would call it a service, is dependent upon there being no curative treatment for the disorder. And lots of people with immunodeficiencies can be treated, but it's not curative, and for which there is severe limitation of quality of life despite contemporary management. Now, I think looking at the list that they have provided, I think that people with immunodeficiencies could argue that they would be similar to the people who have other genetic conditions on the list. The service is being provided for the purpose of providing an assay for PGT, that's a laboratory issue, and the patient has had a consultation with a clinical geneticist. All the IVF companies, if you're having PGT, you have to see one of their geneticists. So really it comes down to the first line, and I've literally just copied this straight from the legislation. So it comes down to this line here, and I think you could make an argument that you would be eligible. But I'm not the person, I'm not the arbiter of the decision, so I think it is worth asking the question. So the advice from the Federal Department of Health is that the genetic disorders that meet the eligibility criteria for these services must have no curative treatment and have a severe limitation on the quality of life despite contemporary management. And then their caveat is, due to the complex and continuously changing field, the eligible disorders are dependent on the professional judgment of the treating practitioner. So you may need your immunologist to help you out. And I will put these links in the chat at the end if you're interested, because it's very new legislation. But like I said, given the other genetic conditions that are on the list and the variable nature of those, I would think that many people with PIDs would also be eligible. So I think that's, if you're interested in PGT, I think it would be worth investigating. A small caveat about PGT: if you are the parents, and I don't know who's on the line, but if you are the parents of a child who has a new genetic condition, so the risk to you as a couple is very low, then as a general rule, we suggest PGT is probably unlikely to be useful. But if you yourself have a genetic condition, and particularly the autosomal dominant, like where the risk is 50%, this is often an option that people pursue. So I guess it depends on the category that you're in, and it's worth having a discussion with somebody. Okay, how does PGT, this is an old diagram, so it's now PGT. How does PGT work? So basically they harvest eggs from mum, they harvest sperm from dad, and they go into the laboratory and they put them together in the petri dish and they make a baby, or they make the embryo. And they let the cells in the embryo reproduce for until day 5, and they get about 100 cells in that embryo, and they remove 1 or 2 cells off the side, and it doesn't damage the embryo in any way. They've been doing it for a very long time, and they can test the DNA of just those 1 or 2 cells. For a long time, the main cost was the $6,000 to $10,000 cost, which I talked to you at the beginning, was this cost here, because the laboratory, the PGT laboratories, have to set up the test individually to you, because they don't have much DNA to work with, so they have to target the testing specifically to your situation. And so the laboratory has to set up specific kind of techniques just for you, and so that's why it costs a lot of money. Once they have that test result though on the embryo though, either they get embryos where they have the condition or they don't. So they only offer to reimplant the embryos that don't have the condition. So you start off the pregnancy knowing that you don't have the condition. So it's a very appealing option, but clearly previously cost prohibitive, but maybe now not so much. You still have to go through IVF, and you're not guaranteed to take home a baby. All right. Last, but certainly not least, is gamete donation. Gametes are just the technical term for sperm and eggs. So some couples opt to conceive using the donation of either sperm or egg, depending on how conditions are inherited. So if the male partner is affected, or if they're the carrier in the family, the couple may choose to opt for sperm donation. And if the female partner is the person who's affected or the carrier, then they may choose to opt for egg donation. And this avoids the need to consider PGT or a CVS or an amniocentesis on an active pregnancy, but you still need IVF. So I guess there are lots of options, but all of this now then requires potentially some sort of intervention in a pregnancy, other than option 1, which is to do nothing. So they're all the things to have a baby about in terms of testing, in terms of PID. Anyone who comes and sees me now, I talk about further reducing your risk of other genetic conditions, and that is via an option to do testing called reproductive carrier screening. So back to our original discussion about how conditions are inherited. All individuals, everybody in the world, you, me, everyone on the phone, all the people in the world, I'm in the hospital, everyone in the building, all individuals are carriers for about 10 to 20 different recessive conditions, either X-linked or autosomal. And it's really only an issue if you and your partner are also a carrier for the same genetic condition. So any couple considering a pregnancy can now undertake what we call reproductive carrier screening. So this now has the option to screen for a large number of recessive conditions, mostly autosomal, but if you're a woman, they will tack on some X-linked, which can cause serious illness in childhood. And the number will range somewhere between 3 and a couple hundred in terms of the number of conditions they screen for. There's currently a national pilot study in Australia, which is trying to prove to the federal government that this should just be provided through Medicare, like a federally funded program. That pilot study is called Mackenzie's Mission. Couples are being recruited through GPs and genetics clinics not genetics clinics, unfortunately, in New South Wales anymore. So if you are based in New South Wales and you have seen a geneticist, we can't recruit anymore, sadly. But you can see your GP and ask them if they are a Mackenzie's Mission recruiter, if you're currently planning a pregnancy. And I suggest you do that quickly because one of my colleagues is on the board at Mackenzie's Mission and they're stopping recruitment in March. So sooner rather than later would be great. Couples who aren't eligible for Mackenzie's Mission can opt to do private carrier testing through a number of other options. And there's an excellent fact sheet. Again, I'm going to put the link in the chat at the end. And it can be ordered through your GP or your friendly genetic counsellor. Unfortunately, it's all privately funded. We don't do any public testing for reproductive carrier testing at the moment. And the out-of-pocket costs will range somewhere usually between about $300 and $600 per couple. And it's important that you do the testing per couple because it's a couple's risk. So if you, as the female, do the test just for yourself and we find out you're a carrier for 3 things, it's only, A, B, and C. It's only a problem if your partner is also a carrier for A, B, and C. If he's a carrier for X, Y, and Z, it doesn't matter. It's about you as a couple. So if he's also a carrier for A, B, or C, then we know that it would be up to 25% chance in terms of your risk. That's now available. You can see your GP. So these are conditions that are separate to your PID. So particularly women who have PIDs, I think it's really important to speak to your healthcare provider about your own personal health and planning a pregnancy, because you may need to consider options for alteration to your treatment. IVIG, as I understand it, is very safe, but please take high dose folate. But also remember, there's absolutely no right or wrong option for any couple. And you will be, if you came to see me or any other genetic counsellor, you would be fully supported regardless of any option that you chose. But we can only test in a pregnancy or do PGT if the molecular DNA cause is known. And clearly I'm in so much of a habit of writing PGD that I still wrote PGD there. So I'm going to put these links in terms of, that's the pregnancy booklet there and the Mackenzie's Mission. I'll put them in the chat at the end. So I'm not sure how many of you have ever seen a genetic counsellor before, because I guess at my hospital, the immune patients get seen to see a genetic counsellor, but I work at a kids hospital, so clearly most of them aren't actively family planning, their parents are. But if you haven't seen one and you want to, we are very happy to help you. We are a limited resource, so it might take a little bit of time to get to see somebody, but nicely, telehealth is much more readily available, particularly since COVID. And again, I'm going to put all the links that I've just talked about in the chat at the end. And the genetic services are all over the country. So this is a very old map that I made. And sorry if you were on my talk last week, WA and South Australia is much more well serviced than this. They have outreach services all over the state. I just couldn't remember where they were when I made the map. So they are based in Adelaide and Perth, but they do outreach all over the country. And now with telehealth, it's much more straightforward. We can really see you wherever you are. And if you can't see, these are the public clinics, but there are private clinics. And essentially, I've got a bunch of friends who work in private practice, and they can essentially see you, from your home. So if you want to talk to somebody like me, it's much more readily available now. And that's really all I had to say. So does anybody have any questions? I'm going to stop sharing. While people have questions, I'm going to pop all of my links in the chat. So feel free to pop questions in the Q&A. I don't think there's anything in there yet. Hopefully that wasn't too overwhelming. Oh, that is a whole link. You might just need to copy it out. I'm not quite sure why it ended up over 2 pages. Oh yeah, oh no, it's going just to, I'll see if I can just copy these back out. For some reason it was just going to just pull Carolyn and myself. Here we go. All right, hopefully everybody can see them. This is the most useful one. So this booklet here that I've just put the link to has all the pictures that I put in, and and a really nice little timeline about when to have all the different tests. So I think that's a really useful resource. And I'm just going to put like all of these three all in one go. Hopefully that works. There we go. So I think that the booklets, pamphlets, prenatal testing, so the third from the bottom, probably the most useful one. It's like a really nice summary of all the things I've said. The other thing that I didn't really say on the summary was talking about the kind of new fandangled just blood tests that people can have, which is called NIPT, or non-invasive prenatal testing, or non-invasive prenatal screening, depending on who you talk to, or NIPS. That is not really a useful thing for, I'm just gonna stop this from rolling. Not really a useful thing in terms of testing for, if you've got a known genetic condition in yourself. So certainly if you've got a PID, NIPT is not useful. It's useful for finding out if the baby's a boy or a girl, and it's useful for checking for Down syndrome, but it's not really useful for much else. So if you've got a known genetic condition in the family, it's not so great for much else. So it's a good place to start, but it won't screen for known genetic conditions yet. So I guess if you think that if you want to have testing for something in the family, I would be going straight for a CVS or an amnio. And you don't need to do NIPT, given particularly that you will be out of pocket for that. You don't need to do NIPT. So hopefully that's clear. I didn't really talk about NIPT, but hopefully that is useful. Any questions, guys? Hopefully I didn't completely overwhelm you. If you don't want to put them in the Q&A, you can just pop them in the chat as well. I think I put all the ones I accidentally put just for the panelists in the other one. Where did I put them? Oh, and I will put my contact details. If you haven't seen a genetic counsellor and you want to talk to somebody, that's my email address. Yeah, I think that's really it. If there's no questions, I'm sorry that it didn't take the full hour, but I mean, I guess really the goal here is that you have to know what the underlying genetic mechanism is in the family, either in yourself or your partner or whoever's affected in the family, and then we can work from there. But if we don't know what the genetic cause is, it makes it essentially impossible to test a pregnancy. But if you've never had a genetic test or no one in the family has had that resolved, there is a lot more testing we can do now. So or if you've never had a genetic test, there's a lot of testing we can do now. So it would be worth reconnecting with your immunologist and having that conversation about, do we need a genetic test? Do we need to do more testing? Because certainly there are options available if you would like to have a test in a pregnancy. And for some people, they want to know, okay, well, does the baby have it so I can be prepared? Totally valid option. Or they want to say, well, I don't want to have a child with this condition, also valid option. Or they want to do nothing, also fairly valid option. So all options are on the table. I guess we want to make sure that you feel supported to do whatever option is right for you, and then we just talk you through your options and then provide you with support. All my pregnant patients I have on a board, until they have a baby, and then we celebrate or commiserate with whatever they need to do. So I think we support whatever option is right for you. And like I said, there's no right or wrong way to go through all of this. So if you have questions, or if there's anything that's been brought up from this conversation that is really challenging, feel more than free to reach out via email, and I'm very happy to, then we can have a chat on the phone if that would be useful, because sometimes people haven't had access to somebody like me before. I definitely see adults, so it will be totally fine to have a conversation. Otherwise, if there's no other questions, I will give everybody an early mark and I will end the conversation. Okay, thanks so much for tuning in. And I know this is the last one for the year. So this will be recorded. And otherwise, I hope everybody has a very nice, restful, festive season. Thanks so much for joining us. Okay, bye.